Thank you for having me. It's an incredible honor to be here to kick off this meeting. As you can see, the conference organizers have done an incredible job. I want to particularly thank Dr. Hallett and Dr. Hussain for inviting me. Actually, this is the second talk I've given to a Canadian audience in a month. I was asked at the ISHLT to talk by the CCS, and given what's going on south of the border, I hope you'll continue to invite me. That talk at ISHLT was actually on marijuana, since Colorado was one of the first places to make it recreational, and I can guarantee you that this talk will be more boring than the ISHLT marijuana talk. We'll try and throw some macaroni in to liven it up. So, can macrodata predict response to therapy? And these are my disclosures. I think the reason that we're talking about this morning is captured by this article that was in Nature a couple of years ago entitled Imprecision Medicine. And I think this figure and quote show you why this is an issue for us. So every day, millions of people are taking medicines that will not help them. The top 10 highest grossing drugs in the United States help between 1 in 25 and 1 in 4 of the people who take them. For some drugs, such as statins, routinely used to lower cholesterol, for low-risk populations, as few as 1 in 50 may benefit. So we know these drugs help people, but they only help a small fraction of the people who are taking them. So now this is definitely true in heart failure. So for our patients with reduced ejection fraction, they now enjoy an embarrassment of riches in terms of therapies. We now have more options or resources than we know what to do with. And I would take you to this recent expert consensus decision pathway that the ACC put together, and I had the pleasure of participating on. But it was really designed to help answer 10 pivotal questions about heart failure with reduced ejection fraction, primarily to take people like you who are clinicians and help you deal with the fact that there are so many things that you're supposed to do for your patients. And the reason for that is, here's a list of evidence-based therapy for these patients. You're supposed to get them on an ACE or an ARB, and then once you do that, you're supposed to get them on an ARNI. Then they need to be on beta blockers. You've got to up-titrate this, even though patients say it makes them feel worse initially. Then you're supposed to get them on spironolactone or eplerenone. If they are in sinus rhythm and still have a fast heart rate, you should consider ivabradine. If they're African American and you've done all that, you still need to give them hydralazine and isosorbide, 2 drugs, 3 times a day typically. You have to refer these patients to our electrophysiologists who are in Boston this week for ICD or CRT. You need to do exquisite volume control with diuretics, and you may need to add a pulmonary artery pressure monitor to help you do that better, especially in patients who are being readmitted for volume overload. And then now cardiac rehab is approved. This is just so much to do. So we have an embarrassment of riches, but it's a lot to deal with. The other problem is that heart failure is not these patients' only problem. So we took 24,000 patients from some of the Kaiser centers across the United States, and we identified those with heart failure. And we found that only 2% of those patients only had heart failure as their only medical problem. 75% had 3 or more co-occurring conditions, and the majority of patients had 5 or more conditions. So when you're dealing with heart failure, you're not just dealing with heart failure. And we all know this. Diabetes, as was mentioned, is a huge problem. So the other is that we tend to think of, HFpEF as only in older women that, have lots of problems, and HFrEF is in younger people. That's slightly true, but the answer is that whatever kind of heart failure you have, it's pretty common to have a lot of problems that go along with them. The other is that these problems don't act on their own. And increasingly, I like to encourage the patients and the people I work with to think about patients and their diseases not as the figure on the left, but as the figure on the right, where they interact with each other. And this is true for the medicines too. If you prescribe one medicine for one disease and another for another disease, you have to think about not only how those medicines interact, but what are the burdens and costs that patients have to face when they are put on this many medicines. So if you think about this, we have a patient with HFrEF, or heart failure. Now 60% of those have hypertension, but actually with the new guidelines coming out, actually it's even more than 60%, and you got to get these patients down to 120 systolic. That's a lot of work. A quarter of them have atrial fibrillation, and now they may be asked to take a NOAC because of lower intracranial hemorrhage, and so they have to deal with the costs of that. Many have diabetes, and now with SGLT2 inhibitors and other agents, we have now a wealth of treatments for diabetes too. But this just adds to the burden of what we can and should be thinking about for our patients. And then half of these patients in my clinic, but at least 20% of all comers with heart failure have coronary heart disease. And now with the new PCSK9 inhibitor trials, are we supposed to add this on top of the therapy that they're already getting? This is overwhelming. So this is medication overload. This is data from 2008, which was in one of the recent guidelines in 2016 that said the average patient's taking 7 prescription medicines up to over 10 doses a day. And that doesn't even count the over-the-counter stuff they're doing, as well as the herbals and vitamins that they think may be helpful. So this is how I think of my life. I've got all these heart failure medicines, and I'm the donkey, and I'm in the air trying to move forward, and it's not working very well. The way that this plays out is that I think we're not doing a particularly good job. So this is some data. It's a little hard to see. But these are patients with HFrEF and a quality improvement registry in the United States that looked at many centers. The very left column shows that about 95% of people are prescribed an ACE or an ARB. Those who have atrial fibrillation, about 80% get warfarin. In the third column, about 95% beta blockers. And then we kind of stop. You know, we're like, I got the ACE, I got the beta blocker, I've got my anticoagulation, and I'm just tired. So we've got 3 great randomized trials that show that eplerenone and spironolactone give you 30% relative risk reductions in outcomes, including sudden death. And the average use of spironolactone and eplerenone in the United States in people who qualify is about 20 to 25%. And it's kind of shocking to me if you look at recent trials like the VEST trial, which really met the criteria for the Ephesus trial, the eligibility criteria. What was the use of spironolactone or eplerenone in VEST? A population that met exactly the criteria for Ephesus. It was 46% in a well-controlled, well-studied randomized trial. So people are just tired. They don't want to do this. And you see this with, now that we have the paradigm trial, and if you look at sacubitril valsartan, if you look at the uptake of this drug, in some data from the United States Get With the Guidelines registry of 21,000 patients during a period where they could have been prescribed ARNI, only 2.3% of people were prescribed that drug. So we have these new advances in therapy, and people aren't using them. So this is also challenging for the patient. So just like I feel like the donkey, so do I think my patients. So, and consistently we see, this is some data from Nitish Chaudhary, who's really, I think, the world's expert on medication adherence and doing trials to improve adherence. And what I think Dr. Chaudhary consistently shows is not only do really clever techniques to try and get people to improve their adherence not work, but what's even more shocking from the MI-free trial and this new Stick to It trial is that if you take people who have clear indications for either post-MI statin or hypertension where they should be taking a drug to lower it, and you prescribe them a drug and you look out 6-12 months, what is consistently the adherence to those drugs? It's about 50%. So, we're working so hard to get these small incremental benefits in the therapies that we derive, and half the people aren't even taking them. So I would argue we need a better approach to make it easier for patients to figure out, and for us to figure out what are the drugs that people really need to take, and then get rid of the ones that aren't going to benefit them so we can really focus. And that's why I think we're having this session this morning to kick off the meeting. So that gets us to the question of, can macrodata predict response to therapy? If I get a lot of data from the electronic medical record, can I figure out from this patient in front of me whether they really are going to benefit from a beta blocker and not going to benefit from an ACE inhibitor? And then I can really focus on the beta blocker, and then I can say, you know what, you're good, let's not worry about the rest of it. Just take that beta blocker at high dose. So we are now blessed with having huge amounts of big data all of a sudden available to us, and we're starting to be able to use it. So there's a number of articles out there. It's hard to read the medical literature without seeing stuff like this. Healthcare is the next frontier for big data. Big data, the ability to collect, process, and interpret massive amounts of information, is one of today's most important technological drivers. While companies see it as a way of detecting weak market signals, and in the United States, ways to influence an election, one of the biggest potential areas of application for society is healthcare. So this is a really nice series in Health Affairs. It's a little bit older, but I think it really captured the big issues at hand. And it says, by discovering associations and understanding patterns and trends with the data, big data analytics have the potential to improve care, save lives, and lower costs. And I think that's partially true. But I think that we have kind of drank the Kool-Aid sometimes, and we haven't really seen the benefits of big data. So we need to think about how to do this better. So big data is a vague term for massive phenomenon that has rapidly become an obsession with entrepreneurs, scientists, governments, and the media. So big data has arrived, but big insights have not. Who cares about causation sampling bias, though, when there is money to be made? So this is a cool example that I really like that one of my mentors, John Rumsfeld, pointed out to me. So this is a company, HBI Solutions. They do a lot of predictive analytics, and they advertise that we can reduce total population medical expense and 30-day readmissions by 10 to 25%. Our performance improvement solution can identify cost savings opportunities of 10 to 40% in target areas while improving quality. So I do a lot of work at our hospital with readmissions. Can we target who really needs close follow-up and a social worker to go home with them, and who is going to do fine and leave the hospital? And I think Dr. Lee is going to talk about some of this work as well. Well, what they did is they actually published this in PLOS Open Access, and they showed that using like big data predictive analytics, that they could predict who was going to be readmitted to the hospital in 30 days, and thus who should get targeted therapy for that. And their C statistics were 0.71 and 0.70 in retrospective and prospective validation data sets. What I think is really interesting is they show this case, which they say is a case that's helpful. And basically they showed that the model doesn't work very well at the beginning on the left, but then they start collecting data on this patient, and they showed that they can really predict this patient's going to come back to the hospital. Well, actually this patient's a 59-year-old woman who had 14 ED visits in the last 12 months. And they showed that after about the 6th ED visit, they could predict that the lady was going to have another ED visit. So that's pretty tremendous. They've done a nice job. So, I think some of this is the law of diminishing returns. We think more data is better, but I think more data is usually incrementally less helpful and sometimes just more confusing. So this is actually the Seattle heart failure model. These are some of the variables that go into the model. And what you can see is if you take one variable, a single variable, what's the diuretic dose, it predicts pretty well how a patient's going to do and whether they're going to die. Then you add systolic blood pressure, it ups you a little bit. But the further you go out and the more data you add to these models, the less you get in terms of predictive capacity. So why big data won't cure us right now? It's that big data solutions are not particularly well connected to care, and without consideration of social uses and clinical practices, big data will fail to cure the woes of our US healthcare system or the Canadian healthcare system. So our big data analytics, we need volume, we have that, we have tons of data. We need variety of data, though, and we really need veracity of data, meaning that we've got to collect the right information, and we've got to combine that with clinical insights to know how to implement the data and make sure that it has clinical impact, and only then will we get better care, better health, better outcomes, and lower costs. I just want to finish up with a couple more thoughts real quickly. One is, the other is that we should use big data to look at who's really at the highest risk. So I think Dr. Lee's going to talk about risk models and things, but remember that those patients at highest risk are the ones who are going to have the biggest benefit. So the number needed to treat is variable. If you have a high-risk population and you give a therapy with a fixed relative risk reduction, the more risk the patient has, the more benefit they're going to get. But for most therapies, the costs and the side effects are relatively fixed. So if we really want to get value out of our therapies, we need to figure out who has the highest risk, who has then the greatest absolute risk reduction based on the relative risk reduction to give us benefit. And the sprint example for hypertension therapy is good for this. So We now have Sprint. It says we should treat like everybody, including most of the people in this room, and that's a lot of work. So can we refine that? And the substantial benefits of intensive systolic blood pressure lowering observed in Sprint came at a cost of increase in serious adverse events, such as acute kidney injury, syncope, hypotension, electrolyte disturbances. So that was higher. And there was a recent paper just published a couple of weeks ago where they stratified the patients in Sprint by their 10-year risk, and they showed that the patients in the highest quartile of risk actually had the most benefit and kind of about the same amount of risk, whereas the lower risk population had more risk, didn't see as much benefit, and so you could tailor based on that. I want to just finish with one last thought, which is that we're always focused on what we can predict, but remember, you should also focus on what you can't predict, because not everything is predictable. So, and I think we fall into this trap of we're doing big data for population medicine, and when I'm in clinic, I'm sitting in front of a single patient, I'm practicing individual care. So here's the Seattle Heart Failure Model or the MAGIC risk score. These come from tens of thousands of patients, big data, you come up with a risk model. So we took 10,000 patients from Kaiser. We estimated their Seattle heart failure 1-year estimated risk of death. And 8,500 patients had a risk score that looks like this, where this is from 0 to 100% predicted chance of death in the next year. These are the risk scores for those who are dead. Interestingly, the average risk was 11% in the alive patients, and it was 17% risk of death in the dead patients. So the dead patients had a slightly higher risk. But the C-index in this population in the validation was 0.69, and what that means is if you pick one alive patient and one dead patient, there's a 69% chance that the score will be worse for the dead patient. But what it also means is that 31% of the time, the alive patient will have a worse score than the dead patient you would have predicted incorrectly. What's more important is what I want to know is who has a greater than 50% chance of being dead in a year, and there's only a few patients in the dead group and a few patients in the alive group. So risk models really give you some data, but they don't work very well for individuals, and so uncertainty is an uncomfortable position, but certainty is an absurd one. So where I've been moving with this is that we do a lot of shared decision making, and I think that this really gets to the fact that we are experts on what options are medically reasonable and what population risk is, but patients are experts on their values and priorities, their hopes and fears, and what they want. So let me finish with this, which is to say that big data and omics can improve our predictive certainty as we get more data if we do it thoughtfully, but don't forget there's always uncertainty. And we want to make sure that we recognize that in what we do and how we talk to patients. Thank you very much.